Development School. Last time we have discussed cardiac symptoms, the major ones: breathlessness, palpitation, dizziness and syncope, pedal edema. These are the major symptoms. Today we will discuss about palpitation on a case-based manner. This is the history of a 30-year-old who presents to the emergency department with complaints of palpitation. He describes the palpitation as that it occurred while at work. It was rapid pounding. He denies any chest pain, shortness of breath, dizziness or syncope. The palpitations are not relieved by rest and had significant distress. It had an onset which is abrupt, and after 30 minutes it's spontaneously resolved. He gives no significant past medical history of any cardiac or respiratory conditions. His family history is negative for any cardiac symptoms or sudden death in the family. So today we will be discussing an approach to palpitations, and finally we will discuss this case. Palpitation is a common and sometimes a frightening symptom. Patients will use this term not only for the undue awareness of one's own heartbeat, but they may also use this for chest pain or breathlessness. So it is very important to verify what the patient feels rather than translating it into palpitation. They may describe the heartbeat as fast, slow, forceful, erratic or irregular, or may feel as a thud or a missed beat. See, these are the usual ways of presentation. It is always a good habit to ask the patient to percuss on the chest wall or on the hand so that you can identify the nature of palpitation. For example, a patient with occasional ectopics will show like this. They will beat. So you can know that the rate is what is the approximate rate, and also you can know what the patient is actually feeling. Hope this point is clear. The history should be elicited very properly. You can use the OPQRSTA format. What is the onset and duration? Should mention how long. Was it abrupt in onset or a gradual? So what is the onset? Second, P can ask about what is the position which occurred while lying down or when standing up. So what is the position? Q is the quality. He can ask us a thud, and what already we have discussed about the quality: rapid one, slow one, forceful one. R here you can use it for the aggravating factors, rate, and any relieving factors. Some patients may say that it occurred abruptly, some may say it may gradually, it may be persistent, somebody may say it may be repeated episodes. So you can ask about this. S stands for the severity. So severity you can assess by asking whether they have a giddiness or syncope. Any palpitation that produces syncope or pre-syncope should be immediately evaluated by a cardiologist. T for the temporal progression, whether it has occurred repeatedly, whether the past history was there, and what any triggering factor is there. So all these can be, for example, somebody has taken alcohol and next day comes with the palpitation. It may be an atrial fibrillation induced by alcohol. That is the importance of then most important associated factors. Whether the patient has got any chest pain, breathlessness, or any other cardiac symptoms were associated with this. So this should be the minimum things you should ask in the history. And during the approach, you should decide whether the patient has got an underlying structural disease or not. So a patient with a normal heart is coming with palpitation, or it is a patient with already a ischemic heart disease or any valvular heart disease coming. That is also important, and describe the symptoms properly. Now look into what are the major causes. You should divide into cardiac causes, non-cardiac causes. That is the most important thing. Many extra cardiac causes. For example, somebody with a psychiatric problem, they can have anxiety may produce symptoms of palpitation. Thyroid disease, hyperthyroidism, always keep in mind somebody coming with a palpitation, irregular or irregular, especially a fast rate. Think about hyperthyroidism. Drugs are important. Beta stimulants, thyroxine, many drugs can induce palpitation. Excessive use of caffeine. The cardiac thing, how you divide into arrhythmias and no arrhythmias. So sometimes it may be due to arrhythmia, sometimes the palpitation can occur not due to arrhythmia. For example, somebody with anemia, they may come with or somebody with a cardiomyopathy, or a patient with mitral regurgitation, aortic regurgitation. So even though there is no arrhythmia, then because of the increased force of contraction, they may complain of palpitation. So basically think as cardiac and non-cardiac. And a quick approach, as I have mentioned, you ask the patient to focus on something and identify whether it is an ectopic. Ectopic will be an occasional jump or a missing beat, or a patient may feel a occasional touch. And second is the rate. What is the rate approximately? You see whether what is the rate in which it is patient is percussing. If the rate is less than 120, for easy, you can think about around 150, it is usually sinus tachycardia. So rate 100 to 150, you take it as sinus tachycardia. A fast one like this and a regular one, take it as paroxysmal supraventricular tachycardia, where the rate is 150 to 250. If it is a fast, at the same time some irregularities is shown, it is a most likely it is atrial fibrillation. So you divide the palpitation into fast one, slow one. The fast one, regular or irregular. Fast and regular, it can be sinus tachycardia, supraventricular tachycardia, or ventricular tachycardia. Fast and irregular, you take it as atrial fibrillation. Sometimes, very rarely, flutter can also produce. So this is a simplified approach. Looking into, is the heartbeat regular? If it is regular, is the rate 120, around 120, 150, it is sinus tachycardia. If it is more than 120 or think around 150 to 250, we take it as most likely supraventricular tachycardia or ventricular tachycardia. So rate 100 to 120, we take it as a sinus tachycardia. It may be due to stroke, high stroke volume. As already I have mentioned, somewhere the mitral regurgitation, aortic regurgitation, they can have, or anemia, thyrotoxicosis, anxiety. All these can present with this sort of. So this is a simplified approach. So some history may be more detail you may take. A single skipped beat I already mentioned is a benign ectopy. Pounding sensation, usually due to again ectopy ventricular premature contraction. Rapid and regular pounding in the neck, it is usually due to supraventricular tachycardia. Especially when the atrium is contracting, that may be felt as a rapid regular pounding in neck. So these are some further details is very difficult to, or it is beyond the scope of discussion today. So palpitation from childhood, always think about supraventricular tachycardia. Somebody has got the heat intolerance and tremor, think about hyperthyroidism. So think about extracardiac problems. So this will be the other causes will be discussed in detail in some other sessions. We take a past medical history. Most important is looking about ischemic heart disease, heart failure, previous cardiac interventions. Always think about the risk factors for heart disease like hypertension, diabetes. Think about pulmonary disease and thyroid. Never forget thyroid disease, hyperthyroidism. Drugs, very important. Antiarrhythmics, QT prolongation drugs, elicit drugs like cocaine, amphetamine. A family history of sudden cardiac death should be asked because some arrhythmiogenic cardiomyopathies, axillary pathways in the family. Such diseases can present with this, so family history is important. The differential diagnosis I already mentioned, divided into cardiac, non-cardiac. Non-cardiac can be psychiatric, drugs and medications, and diseases like anemia, electrolyte imbalance, fever, hyperthyroidism, hyperglycemia. These are all common conditions, pheochromocytoma, pulmonary disease, vasovagal syncope. These are important extracardiac conditions you should keep in mind. So in the physical examination, the most important thing, think about evidence of structural heart disease. Look for extracardiac disease. Never forget hyperthyroidism. And once a patient comes with a palpitation, you have to confirm by a routine ECG, 12-lead ECG. If ECG doesn't show changes, go for a Holt monitoring. That is ambulatory ECG monitoring. We may have to keep the patient for echocardiography, stress testing if you are thinking ischemia induced. The biochemistry, very important. Blood sugar, renal function test, especially thyroid function test. And invasive electrophysiology studies are required in certain cases. Use the technology, smartwatch and smartphones can be useful. There are even reporters are available. And if the cause is not obvious, you may go for invasive electrophysiology study. So this is in short, patient comes with the complaints of palpitation, take a proper history, perform physical examination, take an ECG. Evidence of look for structural heart disease, go for echocardiography and refer to the cardiologist. No structural heart disease, think about extracardiac causes, drug use, hyperthyroidism, manage appropriately. All patients obtain a complete blood count, chemistry, thyroid function test especially, and take the history of drugs, including illicit drugs. And the patient may be further sent for monitoring, telemonitoring, and manage accordingly. So the management depends upon whether the patient has got a structural disease, whether the patient has developed a cerebral hyperperfusion, that is syncope or pre-syncope. Then you have to go for appropriate therapy with the drugs for ablation. So coming back to our patient, the patient has got a rapid onset, fast tachycardia, so abrupt in onset, without any history of any structural disease. Most likely the patient is having a paroxysmal supraventricular tachycardia or PSVT. So PSVT is a narrow complex QRS tachycardia. The most important is abrupt onset. Offset may be abrupt or little gradual. This may be followed by natriuresis because of the patient may pass for urine. This is due to the secretion of atrial natriuretic factor. So each individual arrhythmias we will discuss in another session. Thank you.